everybody. This is Mark Perlmutter teaching my colleagues how to do an injection in the knee. And for patients who look at the station, you'll be able to also see pretty much what to expect when you get your knee injections. We're going to do two different approaches for knee injections today. And one I find particularly valuable if somebody can't get up, if they're lying in bed in the hospital, or if their leg is really morbidly obese and you can't feel the guide, your landmark safely. It's a couple step process. First is to mark where your alignment is. So in this shot, we're going to go between the two joints. I usually exclusively bend the leg at about 90 degrees, and I find the space with my thumbnail between the two bones. She has a tender knee. She has arthritis primarily on the inside of her knee, which is why I'm going on the outside. It's a bigger space. She has a varus deformity, which means she's angled like this on the inside. So I like going in the garage door instead of sneaking through the bathroom window where it's narrower and smaller. It's all one big joint right here. So if you get into the joint, no matter where you get into the joint, you're giving an effective injection. So first thing is to mark it. So I'm right at the joint line there. I'm sorry I hurt you with my thumbnail. Sometimes it's tender there too. And I leave a mark with my thumbnail, and I'll clean it with either chlorhexidine and or an alcohol pad. I like the alcohol pad because I just always keep it handy in case any erythrocytes show up at the end. So the positioning of the needle is critical. It's perfectly parallel to the ground. It's not up, it's not down, and it's 45 degrees, angling dead for the center. I look for veins. I don't see a vein. I do see a vein close by there. I'm going to miss that a little bit. And that's all we have to do. My patient here is very nice to volunteer, but her, like me, are total wimps when needles are aimed at us. So she's being very nice not to holler and scream like she usually does, like I would too. So that's the most common way of giving an injection. There are some people, though, that when they present to you, either can't bend their knee because they're in too much pain, they have an injury, or they're bed bound, and so if their leg is out straight and they can't move, the other approach is to understand that the knee joint goes way up to here. So again, all roads lead to Rome. I just got to get into the joint. So if you go right above the kneecap, which is palpable in everybody, you mark it with your fingernail. And the other way that I tend to mark things is I'll use the capped needle to make a circle. And that way I can come by with my alcohol pad and clean it, my chlorhexidine and really clean it. And notice I always have my Band-Aid ready. She just whispered in my ear to be gentle. And if you go straight down, just above the pole of the kneecap, and it's a no-miss injection. Absolutely, 100% of the time. You drop the needle all the way. I'm using 1.5 inch 22 gauge needles. I don't like 25 gauge needles because they take too long to inject with, and they don't hurt any less than a 22 gauge. So you can see the little erythrocyte collection there. Just so you know, that's the top of the kneecap right at my fingernail. There's the width of the kneecap. We'll hide that with a Band-Aid. And often, even in somebody who can bend their knee, that's a more painless shot because you avoid the joint line completely. That's it for injections. In summary, for other technical points, 1.5 inch 22 gauge needles, I give 6 milligrams of betamethasone or 40 milligrams of Kenalog, and I fill the rest with numbing medicine as a going away present. This is Mark Perlmutter telling you thank you for letting me educate you a little bit, and have a good day.